Hello, everybody. Today we're going to be continuing with NBME 29. This takes so many hours of work. If you're benefiting from this, please like and subscribe. My goal is to help you pass step 1. Here we go. In our first question, we have a 60-year-old man, comes to the emergency department due to hematemesis, reports progressive fatigue and early satiety. He has a history of alcohol use disorder. On examination, he has distended abdomen and shifting dullness with multiple spider angiomata on his chest. Lab studies show mild thrombocytopenia, and hypoendoscopy reveals prominent gastric varices. Imaging shows splenomegaly and a nodular liver. Increased venous pressure, in which the following vessels is most directly responsible for the formation of gastric varices. So here are the answer choices, and the answer is indeed the left gastric vein. And they can ask this several ways. Middle-aged, older man, he's going to have alcohol use. That's guaranteed, right? Why alcohol use? Because that increases the risk of cirrhosis. And on exam, you see the spider angiomata, the hard nodular liver stuff. That means cirrhosis. That's step 1's way of being like, dude, this guy has a cirrhosis liver. And on CT, you see like a mass in the liver. Anytime you have a mass in the liver, what does that mean? Well, that's going to be a possible hepatocellular carcinoma, which is also commonly seen in cirrhotics. And so they'll ask, hey, like which vein is going to be developing the hypertension due to this cirrhosis? In order to answer this question, we have to know a little bit about the portal venous anatomy. Let's just call this your liver right here. And plug it into this liver. We have got a portal vein kind of running along like that. So yeah, that's our portal vein. And again, this big thing right here, this is the liver. Here's like our portal vein. Going off of that, you can have this, which is known as the left gastric vein. And of course, this right here is our pancreas, which makes this right here the superior mesenteric vein. Then you have, your middle colic, your right colic, jejunal, ileal veins. Here's your inferior mesenteric vein. And of course, your splenic vein, which takes you out to your spleen. But right here, that right here is the left gastric vein. And so the portal vein is formed by the splenic vein, superior mesenteric vein, right there. So there's our splenic vein, superior mesenteric vein, and the left gastric vein right there. That's what forms it. And these tributaries include the short gastric veins, right? Those drain into the splenic vein. Anything draining into the portal vein is going to be subject to portal hypertension. And that's because this big old liver right here is cirrhotic. How do we know it's cirrhotic? Because he's an alcoholic, and also because of spider angiomata and hard nodular liver. Also, the mass tells us hepatocellular carcinoma, and a common cause of hepatocellular carcinoma is cirrhosis. And so they're going to try to trick you in various ways. They might say like, oh, the hepatic vein. Well, that drains out of the liver into the IVC. And so that's a little more like Budd-Chiari syndrome, the hepatic vein thrombosis, not cirrhosis. All right, so they might try to trick you like that. In our answer right here, we know the left gastric vein drains both the lesser curvature of the stomach and the lower esophagus. And portal hypertension, increased resistance, causes the backup there, causing those varices. Short gastric varices, which also contribute to gastric varices, drains to the splenic vein, which joins the portal vein. The left renal vein would be Nutcracker syndrome. Hepatic vein is, as we mentioned, Budd-Chiari syndrome. Right suprarenal drains the adrenal gland, and inferior phrenic drains the diaphragm. So if they try to get you on like renal vein, then you should say, no, that's not the answer. Why? Because that drains the kidney into the IVC. One thing we do know is that this short gastric vein, that drains into the splenic and the portal vein. And so that's affected in portal hypertension. And so you get the high pressure right there. All right, for question 92, I wrote down the word infusion because that's the most important part of this question. We have a 22-year-old female who collapses after a marathon. Look at that blood pressure, super low, neck veins are flat. But then we give her isotonic saline and the heart rate drops to 92. Blood pressure improves to 105. What best describes the new hemodynamic state on the graph showing cardiac and vascular curves? Well, it's going to be the same cardiac function curve, but the vascular function curve is shifted to the right. Now, in our question, we have a 22-year-old female, but you can also have a male as well. Totally fine, demographic-wise. Basically, we have a young trauma patient with large blood loss and hypovolemic shock. The findings then would be tachycardia, hypotension, and lacerations with hemorrhage, right? That's typically how this could present, or they could just be dehydrated. And then for management, you give them a rapid infusion. You do volume resuscitation. And what happens in hypovolemia is you have a decreased preload, right? That's the right atrial pressure. And you also have a decreased stroke volume and cardiac output. And so the body, how's that going to compensate? Well, the body's going to compensate with increasing your heart rate, increasing your arterial constriction, systemic vascular resistance. But whenever you give fluids, you're increasing the blood volume, right? So you're increasing the mean systemic filling pressure. And on that vascular function curve, it's going to shift it to the right since the venous return improves at any given right atrial pressure. So it's like we have your cardiac output here, you have your central venous pressure right here. And it's like this on the continuum. You start here, you end up here. You go higher in both. The contractility does not change though, right? You get a healthy heart, there are no inotropes that are given. So the curve is going to stay on that exact same line, but the new intersection point is going to move up along the cardiac curve. So you have a higher right atrial pressure. Why do you have a higher right atrial pressure? More preload. There's also higher cardiac output, right? That's the Frank-Starling mechanism. And there's no change in the contractility. And so you're just going to be on that same kind of curve line with the pressure increased and the cardiac output also increased as well. And it's increased because of the Frank-Starling mechanism, right? The contractility being lowered would be like if you were on a different line. So basically the high yield takeaway here is that fluids cause a rightward shift of the vascular function. Inotropes cause an upward shift of the cardiac function curve. Venodilators cause a leftward shift of the vascular curve, and hemorrhages cause a leftward shift as well on the vascular curve. All right, so that's the high yield takeaway for this graph. Okay, next we have a 24-year-old woman. It could also be a young man as well. So we have both represented in the demographics. Presenting with painful swelling of her left forearm 3 days after scraping in a rock climb. Exam shows erythema, warmth, and purulent drainage from the 2 centimeter area. Biopsy reveals an abundant neutrophil in adjacent vasculature, but limited infiltration into the tissues. Further analysis shows reduced endothelial expression of a molecule normally upregulated by TNF-alpha and IL-1 to mediate leukocyte rolling. Which of the following molecules is deficient? All right, so those are the answers. Now, what I want to teach about this question is you might have all sorts of things. An infection, an abscess from a splinter, right? And what's happening is we have neutrophils and also other leukocytes. They have to leave the bloodstream and enter into the tissue, right? And by the way, a neutrophilic is just something that is stained by neutral dyes. That's why they call it neutrophilic. These are the white blood cells that are important in the immune system that help to fight your body's infections. And usually you have neutrophilia in infections, inflammation, and other neoplastic processes. So like, cancers can cause them. Think like chronic myeloid leukemia as well. Tumors can cause this. Basically, they are the key components of the immune system, the first responders to infection and inflammation. But you can also see them elevated in cancer and due to stress reactions in certain medications. So they're elevated in a whole lot of things. So basically, our neutrophils and our leukocytes leave the bloodstream. They have to enter the tissue. And this question is essentially asking which adhesion molecule first tethers the leukocytes to the endothelium. So we have to know the leukocyte extravasation sequence. It's super, super testable. I've drawn this a couple times, but first is margination and rolling. And there we have the selectins. So you have E-selectin, P-selectin on the endothelium, and it binds Ciala-Lewis on the leukocytes. And that way it can roll along the vessel wall. So if you know that, you know this answer, and you got it. Tight adhesions is the ICAM, the VCAM. Those bind the integrins. And there you think LFA1, MAC1, VLA4 on the leukocytes. That's the ICAM, the adhesion. Then you have transmigration, also known as diapedesis, that happens with PCAM. That's CD31, which, if you guys know my PEG system, is MAT. And so I imagine him rolling out a MAT and then just passing right on through the endothelial cells, because that's what diapedesis, like transmigration, is. And then we have, last one is the migration to the actual site. And that's the chemotaxis. And chemotaxis is directed by IL-8. Also C5a, they love that one for some reason. LTB4, and kallikrein is the last one that they'd ever ask you about. All right, so those are the steps. So we know our answer is selectins. And they could ask you all sorts of things. Here's some examples. The integrins from adhesion, not rolling, you're integrating. Collagen, structural, not involved in the recruitment stuff. Cadherins are the cell junctions, not immune stuff. Matrix metalloproteinases degrade ECM. So yeah, this is essentially a question about the molecular Velcro. It slows down the white blood cells before they fight the infections. You have to know that's the selectins. Cadherins, they help with the adhesion between epithelial, so like the zona adherens, desmosomes. That's more of the cadherin job, so it's not the right answer. Extracellular matrix proteins, that's like the collagen, fibronectin, laminin. That's scaffolding. All right, we're not talking about the scaffolding here. We're talking about the selectins, the Velcro that helps the leukocytes come on in and stay there. G proteins are for intracellular signaling. So yep, we're talking about the rolling step, the rolling phase. All right, here we have a 28-year-old woman found being stranded in the mountains for 6 days. Just so you can see, there are also other demographics it could be. Here's a man. He's also been stranded. Access to melted snow, but there's no food. So she's got water, but no food. Which of the following changes is most likely occurring? Well, I've taken some notes here. We have water, we have no food. That means that we are in a starving state, right? So we're well past the glycogen depletion because the glycogen stores are usually gone after like 24 hours. And the fuel use is going to change. The brain relies on glucose and also ketone bodies. Muscles and other tissues rely on fatty acid oxidation. So the pathways that are upregulated would be gluconeogenesis, because that's how we're going to make new glucose if we don't have any. Lipolysis and also beta oxidation. Maybe also ketogenesis and protein catabolism, because that will provide us with our gluconeogenic substrates. And the downregulated pathways, because these guys are upregulated, would be your glycolysis, glycogen synthesis. It's already exhausted, right? Fatty acid synthesis and protein synthesis. And how they're going to get you is they're going to ask about these intermediates and substrates. They're going to say, okay, would this be elevated or not? Now, you guys are probably looking at this one from your MCAT days and saying, I've seen that before. Well, that is going to be downregulated. That normally activates glycolysis through PFK1. And in starvation, we suppress that, right? So we're going to bring that down. What about pyruvate kinase? Well, that is the last step of glycolysis, and so that's also going to be down. It's suppressed so that the substrates can go into the gluconeogenesis instead. And then there are some other steps that are involved in gluconeogenesis, right? And that's like glucose 6-phosphatase. That's going to be upregulated. That's the final step in gluconeogenesis, right? That's where you release the free glucose into the blood. And PepCK is the key step in gluconeogenesis as well. So PepCK is going to be elevated, whereas the other guys are going to be decreased. So prolonged fasting, the liver shifts toward the glucose production and also exports, not utilization. And so the key aspect of this topic is knowing that PepCK and glucose 6-phosphatase are upregulated, and glycolysis enzymes like pyruvate kinase, PFK1 through fructose 2,6-biphosphate are going to be downregulated. So downregulated, upregulated, glycolysis, gluconeogenesis. And so our answer is increased phosphoenolpyruvate, PepCK, and glucose 6-phosphatase. There we go. The answer is D. Pyruvate kinase and fructose 2,6-biphosphate promotes glycolysis. Malonyl-CoA is seen in the fed state, downregulated in fasting. Suppressed G6-PAs. Well, that's needed to release the glucose in the bloodstream so you can't depress it. High citrate builds up only in high energy fed states. So yeah, your liver actually kind of turns into like a glucose factory after 24 hours of not eating. Your liver's like, let me fix that. So your body's starved of food and it just adapts. Your hormones just change and it just flips your metabolism around. No big deal. All right. In our next question, we have a 35-year-old woman presenting with fatigue, blurry vision, and persistent dry cough. She has recent joint stiffness and painful red nodules in the shins. I'm also giving you this demographic because I think it's super important to also know for test A. Her temperature is 99.5, blood pressure is 120 over 76. Ophthalmologic exam shows anterior uveitis. Bilateral hilar lymphadenopathy is present. We also have elevated ACE levels. Transbronchial biopsy revealed well-formed non-caseating granulomas. This should all be making us think of sarcoidosis. Bilateral hilar lymphadenopathy, uveitis, erythema nodosum. Are you kidding me? This is sarcoidosis 100% of the time. Now, what's the predisposing factor? Well, anytime you see a patient with bilateral hilar adenopathy, lymphadenopathy, and maybe they'll have like a paratracheal enlargement, and on biopsy, they're always going to show you non-caseating granulomas. What they're trying to tell you, they're just screaming it out to you, is sarcoidosis, okay? There's some key diagnostic features for sarcoidosis. Non-caseating granulomas, bilateral hilar lymphadenopathy, and African-American population, and also women. Those are the most important things to know. You should also know outside of that it's like 20 to 40 years old. I've never seen a question where they're not. African-American, women, 20 to 40, bilateral hilar lymphadenopathy and non-caseating granulomas, just literally click sarcoidosis. It is right every single time. Anytime you see those patient characteristics, it's going to be sarcoidosis. Now, the manifestations are uveitis, erythema nodosum, hypercalcemia. And the hypercalcemia is interestingly from increased alpha hydroxylase activity in the macrophages. And I think this is an important mechanism to know. The macrophages increase alpha hydroxylase. And you could also see restrictive lung disease if it's chronic as well. And so what I'm doing here in this question is I'm just teasing out these risk factors, which are super high yield in the exam these days. Sarcoidosis, non-caseating, hypercalcemia, female sex, it's all strong. Bird exposure is hypersensitivity to pneumonitis. Smoking is not a risk factor for it. In fact, it may actually be protective. Northern European ancestry is not it. It's African-American ancestry. And travel to Arizona is coccidiomycosis, caseating granulomas. Now, sarcoidosis is often called, interestingly enough, the great mimic, because it can resemble like everything from like lung cancer to tuberculosis, honestly. Okay, next we have a 13-year-old boy recovering after surgery for a displaced supracondylar humerus fracture. His arm was immobilized in a long arm cast for 4 weeks. After follow-up, he reports difficulty performing push-ups, which he used to do them easily. Physical exam reveals visible muscle thinning of the triceps and deltoid. Which of the following is most likely observed? So we got a young kid, forearm fracture, immobilized, in a cast. And then 3 weeks later, the muscles are no longer going to be used. what happens to these immobilized muscles? For this one, we have to talk about use and disuse. So active loaded muscles have increased metabolic rate, increased mitochondrial activity, and also increased angiogenesis, and that's through VEGF. You also have increased capillary density, and you have increased local vasodilators like adenosine, lactate, CO2, hydronium ions, right? So you're going to have like increased blood flow. If you're inactive, then you kind of have the opposite. You have decreased trophic stimulation. There's another word for that would be like you have atrophy, increased atrophy. You also have decreased metabolic demand. There's atrophy of the sarcomeres. And most importantly, we decrease your VEGF. There's decreased angiogenesis signals. There's decreased capillary density. So he has his arm immobilized, and the answer is going to be microvascular density. So yeah, you just hold your arm like this, don't even move it, put it in a cast 3 weeks, your muscles are going to shrink, and also the blood supply does too. It starves your muscles. Now, these other answers are interesting. Increased mitochondrial biogenesis would be like if you're training for a marathon, doing endurance training, you could see that. Increased tissue oxygen extraction would be ischemia. HIF, 1-alpha expression, hypoxia. That's when it's not reaching the tissues. And increased intracellular lactate would be anaerobic glycolysis. That's wrong because inactive muscles don't perform anaerobics. Next, we have a 24-year-old man with recurrent generalized tonic-clonic seizures that began 3 weeks ago. Immigrated to the United States from Guatemala. Denies any history of trauma, substance use, or past medical issues. Neurologic exam is unremarkable between episodes. Non-contrast CT of the brain reveals multiple cystic and calcified lesions scattered throughout the cerebral cortex, some with central dot-like structures. Blood tests are normal except for mild eosinophilia. Which of the following is the most likely causal organism? Now, you could also see this in old, young, male, female, and so here I have a young female. This person is usually going to be an immigrant of Guatemala, Mexico, something like that. So multiple cystic calcified lesions, central dot-like structures, and their new onset seizures. Usually the most important things to know about this particular issue is that they're going to be previously healthy. They're from Mexico or Guatemala. They're an immigrant essentially. And then out of the blue, they have some short amount of time where they start to get seizures. And then the CT of the brain shows multiple calcified nodules and also some cysts. So cyst and nodule. Everything else is pretty normal. So it's really that multiple cystic and calcified brain lesions that's in somebody from Latin America that tells you it's Neurocysticercosis. So watch out for that dot sign. Taenia solia, it's the larvae that are responsible. And the seizures are common due to the inflammatory response around these cysts. So the cysts get all ugly, inflammation happens, you have 1 week of just seizing in a previously healthy person from an endemic region, and also you have some nodules. That's pretty much all there is to know about Taenia solium. Now, they'll try to confuse you, and they'll try to make you think of other conditions like Cryptococcus neoformans, but that one is not going to lead to the symptoms we see in this patient necessarily. Rather, it leads you a little bit more toward meningitis. And that's usually in immunocompromised individuals, not previously healthy people, and definitely you're not going to see multiple cystic lesions. Herpes simplex virus would cause encephalitis, and that's usually in the temporal lobe, necrosis. And HIV predisposes you to opportunistic, so CNS infections. Listeria causes meningitis and abscess. Streptococcus pneumonia, that's meningitis. Toxo would have multiple ring-enhancing lesions in immunocompromised. You have to know that this is a previously healthy child. All right. Or a previously healthy 24-year-old man. Started 3 weeks ago. All right. Here we have a 28-year-old woman. It could also be a 28 or something-year-old man. Just showing you a different demographic. Could be nearly anybody. Nasal congestion, watery rhinorrhea, sneezing for the past couple of days. The symptoms occur every April and October. Okay, so some allergies. You have boggy, pale nasal mucosa with clear discharge. She wants immediate relief for the upcoming job interview. What drug are you going to give her? Probably phenylephrine, short-term relief. Kind of contraindicated in the elderly because of Beer's criteria. Short-term relief would be an alpha-1 adrenergic agonist. So there's our answer B. And the pathophysiology is interesting here. In allergic rhinitis, you have histamine release and parasympathetic activation. And that causes vasodilation and increased secretions of the nasal mucosa. And so for treatment, long-term, you give them intranasal corticosteroids like oral intranasal antihistamines. So you stop those histamines from spreading out. And short-term, immediate relief, you give them an alpha-1 adrenergic agonist. That could be topical oral decongestants. So alpha-1 adrenergic agonists would be like phenylephrine, zoline, pseudoephedrine. Those are alpha-1 activators, vasoconstricting. And so they constrict on that nasal mucosa, and you get decreased edema, decreased secretions, and rapid relief. You also have alpha adrenergic antagonists, and those guys would cause, vasodilation, and that would make things worse. Beta adrenergic agonists, like albuterol, use this for bronchodilation for asthma. Beta adrenergic antagonists would be like propranolol. Nicotinic cholinergic agonists would be like nicotine. That would not even help. So our answer is indeed going to be B. Well, the muscarinic antagonist would have a drying effect, but wouldn't have that relief. It's more used for COPD. H1, histamine receptor antagonism, used for itching and sneezing, slower onset, not ideal for acute relief. Leukotriene, montelukast, used for asthma, not fast acting, and a corticosteroid nasal spray would be long-term control, slower. So a lot of people have allergic rhinitis. The reason why is because that springtime pollen will hit, and so you got to get some sort of relief. So you got to constrict that nasal mucosal vessel. All right, so here we have a 31-year-old woman with a history of poorly controlled type 1 diabetes, evaluation of chronic bloating and early satiety. It's not specific to female, so I've given you a male over here as well. She started a new medication that binds to receptor in the smooth muscle of the upper GI tract and improves gastric motility. What describes the mechanism? All right, so we're increasing the contractility of the stomach. Well, there's this thing called the migrating motor complex, the MMC, and that causes the waves of the electrical and contractile activity that occur during fasting about every 90 to 120 minutes. And so the function is going to be it clears the residual food and bacteria between the meals. It's like a housekeeping. And Motilin is the hormone that initiates that motor complex. It activates the G protein coupled receptors. It increases the gastric contractions, the antrum, the fundus. It stimulates the peristalsis of the small bowel. And so clinically, like erythromycin, which is a Motilin receptor agonist, is used to stimulate the gastric motility. So our answer is B, the activation of the Motilin receptors. Gastric varices, diabetes, impaired MMC, Motilin, agonist like erythromycin stimulated. D2 antagonist, metoclopramide acts this way but causes extrapyramidal symptoms like tardive dyskinesia. It improves motility indirectly, not through the MMC. 5-HT3 blockade, ondansetron, does not stimulate motility, but it does block the emetic pathway. Hydronium potassium ATPase inhibitor, proton pump inhibitor that reduces the acid on the motility. CB1 promotes the hunger. So basically for this question, we need to know that your stomach has its own cleaning cycle every 90 minutes or so. When you're not eating, there's this migrating motor complex. It's powered by Motilin, and erythromycin can actually mimic that. So serotonin is more of a modulator of like that 5-HT, your motility and secretion, but the effects are going to be super broad and stuff. The direct triggering of the MMC, like this question is asking, is going to be Motilin. Norepinephrine would be sympathetic, that would decrease motility. Acetylcholine would be a vagal parasympathetic, so it would stimulate secretion and motility, but it's not going to be the most specific example. Bind to the smooth muscle of the upper GI tract and improve the motility. Motilin. 28-year-old healthy man is hiking a mountain lodge situated at elevation where the atmospheric pressure is at 600. Alveolar carbon dioxide partial pressure is 40. Respiratory exchange is 0.8. What is his estimated alveolar partial pressure? All right, so breaking this down, atmospheric pressure is 600. That's where our altitude is. Fraction of oxygen and ambient air is 0.21. And this is going to stay constant at altitude. The water vapor is constant at 47. So you would subtract that from atmospheric pressure. And then we use the alveolar gas exchange equation, which is going to be this guy right here. So we just plug it in to our equation and we get 66. And we have to subtract the water vapor. That's like the only hard part of this is subtracting the water vapor. And you get 66. Now, I hate this because it's a lot of just memorization, right? The big thing to know is that the fraction of inspired oxygen in room air would be 0.21. You just have to know that. The water vapor pressure at the body temperature is 47. That's what you need to know. If you know that, you're good to go, okay? These two variables are worth memorizing. And with that, we'll see you soon for the rest of the video. Hello, everybody. NBME 29, question 101. All right, this is an ethics question. We need to make sure that we always validate the emotions. Okay, so here's your practice question. 23-year-old college student is brought by his sister due to changes in behavior the past 8 months. She reports he has isolated himself, stopped attending to classes, and frequently mumbles to himself in his room. He has not bathed, he's unkempt, makes erratic eye contact. His sister begins to cry, saying, "I don't even recognize him." Which of the following is the most appropriate initial response by the physician? The answer is, that must be incredibly difficult. Can you tell me more? Always validate first, right? Whenever anybody describes emotion when discussing a medical concern, the physician should always be like, I agree that it's X emotion that you're feeling. Always validate. After you validate, then you can start to ask the open-ended questions. Okay, they're the trap answers why they're wrong. So here are some notes. Validate emotions, ask open-ended questions, don't jump to diagnosis, don't offer judgmental advice, like, oh, you need to shower. Also be on the lookout for positive symptoms of hallucination. Negative symptoms would be the poor hygiene, social withdrawal. Schizophrenia would have both clusters over 6 months. All right, next we have a 73-year-old man, but it could also be a woman. Here I have that in my demographic photo. Coming for routine evaluation, reporting no significant complaints. Lab shows an M spike of 2.1 on serum protein, electrophoresis bone. Marrow biopsy shows 5% plasma cells. His hemoglobin is 13.2, calcium 9, creatinine is 0.9. He denies bone pain and fatigue, weight loss, has no lytic lesions. Which of the following is the diagnosis? Correct answer is D, monoclonal gammopathy of undetermined significance. So there are some things that we have to kind of know here. The M spike would be less than 3 for this condition and also less than 10% of your plasma cells in the marrow. And most important, like on step 1, is to know these CRAB symptoms. You probably heard of CRAB, really good acronym. That's hypercalcemia, renal failure, anemia, bone lesions. He denied those things. It's super important that they mentioned that. And this condition is benign, but it can progress later on to a melanoma. It's about like 1% per year. There are some other answers like smoldering. And I'd say, okay, what's smoldering myeloma? That's an M spike that's greater than 3 grams per deciliter or greater than 10% plasma cells. And there you would have your CRAB findings, right? So it's all about that hypercalcemia, renal failure, anemia, and the bone lesion stuff. There's also Waldenstrom macroglobulinemia. And there you have an IgM spike, not an IgG spike. There you have like headaches, blurred vision, bleeding, neuropathy, that stuff. Chronic liver disease and chronic inflammation. That causes polyclonal hypergammaglobulinemia, not a sharp monoclonal spike. So what we're going to be doing on a question like this is we have to match it to the vignette, right? Here we have an M spike of less than 10% in the marrow and no CRAB features. Multiple myeloma has those lytic bone lesions, and you need greater than 10% of the plasma. Smoldering multiple myeloma would be asymptomatic with an M spike of greater than 3. Here we had an M spike of less than 3. Waldenstrom has a monoclonal IgM, you know that because the M there, Waldenstrom IgM hyperviscosity. And CLL would have the smudge cells. And the way I like to remember this one is, I can see clearly now the smudge has gone, right? I can see I always remember clean, clearly. Now the smudge is gone. Lymphocytosis with smudge cells. All right, so we got a 73-year-old, totally fine. But now we have an M spike, 5% plasma cells. There's no CRAB, MGUS. Early stage clonal plasma cell disorder. For management, it's just monitoring, labs and symptoms. No treatment is necessarily needed with this. It's monoclonal gammopathy of uncertain significance. So simply, just to make it really clear, anytime you see multiple myeloma, you should look out for CRAB symptoms. And also you need greater than 3 gram per deciliter spike or greater than 10% of the plasma cells. And also you need those CRAB symptoms. Smoldering is greater than 3 spike but no symptoms. Waldenstrom is an IgM spike, not IgG. Chronic liver disease and inflammation would have a polyclonal increase, not just one single sharp spike. So we got this disease, kind of harmless for now, but that's what's going on in this patient. Okay, next we are on 103. Here in a study of vascular permeability, researchers apply a mild heat stimulus on the dorsal skin of rats for 20 seconds and observe biphasic extravasation of the injected dye. First peak occurs in 20 minutes. Second, broader peak after 4 to 6 hours. Follow-up trial group of rats is pre-treated with non-sedating H1 blocker. Which of the following best describes the effect of the antihistamine? Okay, so basically after you get like a burn, you have 2 waves of leakiness, which is another word for extravasation, leakiness. There's an early one and there's a late one. This early one is just minutes after, and it's driven by mast cell histamine, and that is H1. That causes arterial vasodilation and venular endothelial gap formation. And so this causes the plasma to go ahead and leak out. Then there's this later peak that's hours later, and that's driven by the cytokine mediators from the damaged tissue, and it's recruited leukocytes. So like TNF, alpha, IL-1, prostaglandins, bradykinin, all that stuff. So an antihistamine will block the early histamine mediator response, and it'll blunt that first one, antihistamine, and not necessarily this second one. Cytokine-mediated inflammation persists independent of histamine, preventing both peaks. Delays onset of the second peak. Cytokines are released. Attenuates only the late peak. Antihistamines do not affect prostaglandins and cytokines. Has no effect. Histamine clearly mediates the initial vascular response. So here's a little explanation if you want to pause. There's that first wave, second wave, first wave. Mast cells dump histamine, get dilation and capillary leakage, early fluid leak, and then cytokines TNF alpha show up. There's a second wave, right? So our first, histamine, mast cells, and then you have the swelling that's caused by the cytokines. Histamine, cytokines. All right, so in this next question, we need to know about the external iliac artery. There's the psoas major, there's our femoral artery, common iliac, external, inferior epigastric, and the deep circumflex iliac artery. There's this inguinal ligament here. And there are a couple of things. There's the uteropelvic junction. That's where the renal pelvis meets the ureter. There's the pelvic brim. That's where the ureter crosses the external iliac vessels. So, your renal pelvis, ureters, bladder, ureter, external iliac, psoas major. Just trying to show this from different angles. Uteropelvic junction right here, iliac artery right here. That's a good little drawing. So this uteropelvic junction, that's where the renal pelvis meets the ureter. You can see it right here. Uterovesicular junction, that's where the ureter enters the bladder. And then the pelvic brim is where the ureter crosses the external iliac vessels. All right, so those are kind of the big 3 sites, the ureter narrowing sites, and that's where the stones often will get stuck. And so in this question, they're going to be like, hey, we got like a stone. It's just chilling. It's above the sacroiliac joint. Okay, well, that's going to be the pelvic brim. And at the pelvic brim, the ureter crosses the external iliac vessel, and that is what narrows the passage. So here you can kind of see it in this photo. If I zoom in right there. See how it's kind of crossing right there, right at the pelvic brim, your pelvic junction. Yeah, this is a pretty good photo. You can kind of see these 3 distinct spots where it's going to be narrowed at. And those are the external iliac. So in this question, we have a 28-year-old G1PO, 20 weeks gestation, sudden right-sided cramping, flank pain, anterior thigh with nausea. No fever. Passes anterior to which structure? External iliac artery. Here's the explanation. We kind of looked over this together. But what there is to know is that the ureteral stones are going to get stuck at the 3 most distinct and kind of predictable choke points: uteropelvic junction, the pelvic brim, uterovesicular junction. So it's where the ureter crosses the external iliac vessels, and then where the ureter actually enters into the bladder. Those are the 3 areas you should know. And so stones just above that sacroiliac joint, that's the pelvic brim. And at that pelvic brim, you're going to cross the external iliac vessel. Ta-da. All right, for this one, we're going back to the drawing board. We are on question 104. So let's talk about an ROC curve. So typically how this plays out is the y-axis. This is like the sensitivity. See how it says true positives? That's the same thing as sensitivity. X-axis is 1 minus the specificity, which is to say the false positive rate. And so, if it's higher up, then that means it's more sensitive. There are fewer false positives. And so if you're looking for like a fatal disease, the most important thing is you don't want to miss anybody who has it, right? You want that cut point to be at where the highest sensitivity is. If you pick a very sensitive cut point, then you're going to get more false positives that has lower specificity. And that's fine if you're screening, because positives can then be confirmed with more specific follow-up testing. But false negatives, like missed cases being deadly, that's super bad. So on an ROC curve, like over here, would be the highest sensitivity. So if it's a serious disease, but it's treatable, definitely pick the most sensitive test. And you can remember this by, if it's sensitive, remember SNOUT. Sensitivity being negative rules out the disease. So here it says a new blood-based assay is being developed to detect an aggressive cancer that is asymptomatic early but rapidly fatal if not treated. ROC curve below demonstrates 5 potential cut points based on assay values. The goal is to use this assay for population-wide screening. Which cut point should be selected to maximize early disease detection? And then they're going to give you an ROC curve that kind of looks like this, and it's going to be the one that's highest up, right? Because that's going to be sensitivity. Sensitivity, if you're sensitive, it's truly a positive trait, right? In a person. You want somebody who's sensitive in a person, right? Well, it's truly a positive trait, so it's true positive. You want that to be as high as possible, because SNOUT, if it's sensitivity, it has a high sensitivity, but it's negative, that rules out the disease, SNOUT. So the answer is E, which is right here, super high up. The other ones are going to be lower. Yep, ROC stands for receiver operating characteristic. You don't want somebody thinking that they're fine, but they're not, if the disease is fatal. If it's not fatal, sure, it's fine. So that's the ROC curve. All right, here we have a 17-year-old male evaluated for academic difficulties and behavioral issues. His teachers report poor social interaction and repetitive speech. On exam, he has long, narrow face, enlarged ears, and macroorchidism. Family history reveals maternal grandfather with late-onset tremor and ataxia. We have a lot of these 250 CGG repeats. That was overkill of them to say. Which of the following describes the consequence of this mutation? It is the transcriptional silencing through DNA methylation. All right, so this, we move on, is Fragile X. The GG stands for giant gonads. That's the way to remember it. But it's a CGG expansion of the 5' UTR of the R1 gene, FR1. So that region becomes hypermethylated, and the methylation blocks the transcription factor, RNA polymerase access, and then the transcription gets silenced. So you decrease FMR1, mRNA. So you can remember this as like the giant gonads, the CGG, or you can say it causes it to go quiet. Causes gene to go quiet. FMR1, giant gonads, Fragile X. The phenotype is intellectual disability, long face, large ears. So maybe another way you can remember this too is the C kind of looks like large ears on a person. See like that? And then giant gonads. All right, so you kind of can imagine a person, and that's just the way that has stuck with me for Fragile X. It's not increased translation. It's not actually translated, it's silenced. Increased intron, splicing affects the mRNA, but the transcript's not made there. Incorporation, it's not applicable. It's in the non-coding region, never entering. Impaired nuclear export, there's no mRNA to export due to the transcriptional silencing. It's the most common inherited cause of intellectual disability. So the splicing defects, that's the intron exon stuff. mRNA degradation, that's poly A issues. Incorporation, the repeats are not transcribed at the mRNA, they're going to silence upstream. So like all these like repeats that you have, the repeats are not transcribed into mRNA. They just silence. So methylation would reduce the binding of RNA polymerase as well. Also, I realized that my photo was kind of blocking everything there, but hopefully you can see my notes here on Fragile X. And now I'm going to move on to 107. All right, here a 71-year-old woman is presenting with difficulty swallowing that began gradually over the past 3 months. She reports occasional coughing while eating and has unintentionally lost 4 pounds. She denies any neodynophagia or regurgitation. Her recent medical history shows hypertension and remote history of rheumatic fever. Chest x-ray shows cardiomegaly with a prominent left heart border. Barium esophagram reveals posterior displacement of the mid-esophagus. Which of the following is most likely responsible for these symptoms? Okay, you have to know how the heart sits for this one. So I'm going to go ahead and give you the answer. It's the left atrium that's the most posterior chamber of the heart. It lies just in front of the esophagus and the mediastinum. And if the left atrium enlarges, for instance, if we were to have a dilated cardiomyopathy, right? If something like that were to happen, or you were to have like a mitral valve disease or something like that, then it can press up and displace the esophagus. And that will show up on the barium swallow as a posterior indentation, and that will cause dysphagia, especially to solids. The left ventricle, that's more inferior and also lateral. The right atrium, that forms the right heart border. The right ventricle is the most anterior chamber, and the superior vena cava is not adjacent to the esophagus. So left atrium lies directly anterior to the esophagus and posterior to the mediastinum. So yep, an enlarged heart can make it hard to swallow. That's the main story here. You have to know that it's left atrium, which sits like directly in front of your esophagus. And always try to envision like a patient in front of you, staring at you like you're diagnosing them. That left side, the heart's kind of tilted like this, looks like a boot inside of their body. Also on that last one, if you want to remember, LA stands for lies against. Maybe that's an easy way to remember it. It lies against the esophagus. LA, left atrium. Okay, next we have a 26-year-old man presenting to the clinic with recurrent episodes of colored urine that last 1 to 2 days. After episodes of pharyngitis, he denies dysuria or flank pain. Past medical history is unremarkable. Blood pressure is 140/88. Physical exam is normal. Urine analysis shows 3+ blood, 2+ protein, and dysmorphic red blood cells. Renal biopsy shows granule immune deposits in serum. C3 and C4 are normal. Okay, this is IgA nephropathy. So we got a dude, he's got some episodes of some brown urine, hematuria, that appears during a respiratory infection, URI, GI problem. And this is going to be IgA nephropathy, Berger disease. And this happens because of mucosal infections like respiratory GI, and that will trigger an IgA overproduction is the mechanism, and that deposits in the glomerular mesangium. And so on biopsy, you have granular IgA deposits in the mesangium, and you could think of other options like IgD. Nobody really cares about that one. That's only on the autoimmune B cells. Or IgM, that's really early in the process of the immune response. It's not going to be the driver of Berger disease at all. That's IgA. And IgE is allergic reactions, not the kidney. So IgA nephropathy, the infections activate the IgA. You get hematuria with colds or GI problems. Here's an explanation. Linear IgG would be Goodpasture syndrome, full house pattern, lupus, low complement, and all that stuff. IgM, focal segmental glomerular sclerosis, is a pattern in HIV. Subepithelial humps, IgG and C3 is post-streptococcal glomerulonephritis. So it causes blood in the urine just like a day or two after you have an upper respiratory infection. All right, here's some more information about it. Granular IgA in the mesangium, nephropathy with the young adult, hematuria after upper respiratory infection or GI, red blood cell cast, and normal C3. It's not lupus or Goodpasture. Linear IgG is a type 2 hypersensitivity reaction where the answer is Goodpasture's. You have a glomerular basement membrane, and inside of that, the alpha-3 chain of type 4 collagen is damaged with those IgGs. So you have linear IgG staining. IgA would be granular, not linear. Also involves the lungs. Hemoptysis would be seen. All right, and this next question, look, it's you, a researcher. Oops, there we go. They're comparing the energy yield of different organic compounds, each containing 6 carbon atoms. Researcher observes that one compound generates significantly more. Which of the following characteristic most likely explains the higher ATP yield, has a greater number of hydrogen atoms? So basically, I don't know if you guys have seen those awesome animations, but the human body has like a turbine system where it just shuttles these hydronium ions to make ATP. That's pretty much how it works inside of your cells. And so more hydrogen atoms just means that there's a molecule that is more reduced. So it can donate more electrons to NAD plus and FAD also to make more NADH and FADH2. That causes more ATP for oxidative phosphorylation. And that is why fatty acids, which have it's a very hydrogen-rich molecule, yield more ATP than than carbs or alcohol, right? Does that make sense? We have all these hydrogens, right? So it's like the turbine can really get going with those fatty acids. it's not like the aldehydes or the keto stuff. That's already partially oxidized, right? So you have fewer electrons that you give up. It's not going to be oxygen atoms, right? It's not oxygen atoms because more oxygen means more oxidized. And so you have less potential for that ATP generation. The amino groups don't drive a lot of electron yield. Nitrogen has to be removed first. The amino groups have to literally go through the urea cycle before the ATP can be harvested. So here's some explanation. Hydroxyl groups partially oxidized, less hydrogen available. The carbonyls have already been oxidized. They already lost their electrons. Peptides, nitrogen containing. So it's all about those hydrogen atoms. Oh yeah. All right, this is a great question. And see if you can get it just only based on the description alone. 20-year-old college student, urgent care, acute chest pain, shortness of breath after playing basketball, denies cough, fever, trauma. He has a history of asthma with albuterol. He's anxious, tachypnic. Vitals are 98.6. His trachea is midline, and auscultation breath sounds are decreased on the right side of his body. Percussion shows hyperresonance over the same area. All right, what's the finding? The answer is going to be decreased breath sounds on the right. I know it already said that, but the point here is to identify and describe spontaneous pneumothorax. If you have a young male with asthma and thin body habitus, they might have a ruptured little bleb there, and hyperresonance and decreased breath sounds shows you that you have some air in that pleural space. So there's primary spontaneous pneumothorax. That's a rupture of the apical subpleural blebs, usually in tall, thin males when they're exerting themselves. Tension pneumothorax will also add the tracheal deviation, JVD, and severe hypotension. And for that, you need an emergency needle decompression. So pneumothorax, right? Pneumothorax, you think of the P for popped lung. You have absent breath sounds, hyper-resonant percussion, and sudden chest pain. These are good to know too. Increased tactile phrenitis is seen in pneumonia, but is decreased because of air insulation. Crackles, lung disease. Diffuse wheezing would be an asthma. Bronchial breath sounds, left apex would be consolidation. There's about 1 in 20,000 healthy males experiences this. But yeah, somebody's got like the chest pain, shortness of breath all of a sudden, and X-ray shows a left pneumothorax. A left pneumothorax, by the way, would just mean that there's air in the pleural space. And so in pneumothorax, the lung collapses and you hear like very little or no breath sounds on that particular side. And the chest also sounds kind of like hyperresonant and like hollow whenever you tap it. Crackles tell you about pneumonia, fluid, fibrosis. Wheezes tell you about asthma, and rhonk is mucus in the airways. So pneumothorax is the collapsed lung and causes decreased breath sounds on the affected side. So really just to drive this home, what about like a normal pneumothorax? Well, a normal pneumothorax, air gets into the pleural space and the lung on that side collapses. So pressure is inside that pleural space and it starts to equal the atmospheric pressure. It's not building, right? And there's no tracheal deviation in a normal pneumothorax. Or there's like a really mild that's like toward the collapse, but don't worry about that. That's only if there's volume loss, like in lectasis. Tension pneumothorax, that's where you have that high pressure. Percussion's hyperresonant, just like in pneumothorax. Breath sounds are decreased or absent, but the trachea deviates away from the affected side because of that pressure pushing the mediastinum. Atelectasis is the lung collapse because of that obstruction. So usually in atelectasis, it's like a mucus plug, or maybe you have like some sort of a tumor. And the breath sounds decrease on that affected side. The percussion is dull. So the trachea deviates toward the affected side. The volume loss pulls it over. Pleural effusion is where fluid collects in the pleural space. There, the breath sounds are going to decrease for a pleural effusion. It's going to be dull, and the trachea has a small effusion, usually none. A large effusion, it can deviate away because like the fluid literally pushes it out. And the only other thing we haven't really covered is consolidation. For instance, pneumonia, and that's the alveoli that are filled with pus or fluid. The breath sounds there, bronchial, crackles, agophony. Percussion's dull, and the trachea stays midline there. So just in general, I think what you should remember is that pressure pushes, right? Tension pneumothorax, large effusion. The trachea goes away, volume decrease like atelectasis, the trachea goes toward you. And then regarding like the breath sounds, percussion, and all that stuff, in the pneumothorax, you have air in the pleural space, right? And so the breath sounds are going to be decreased, but the percussion is going to be hyperresonant, hollow, and the trachea is simple, midline, nothing. But if there's tension, then it deviates away. So that's pneumothorax for you. Breath sounds decrease, percussion's hyperresonant. Atelectasis has a collapsed lung, and there you have the breath sounds decrease. There the percussion is dull, there's no air, and the trachea is toward the affected side. Pleural effusion, you have fluid in the pleural space, so the breath sounds are decreased. You have that dull kind of percussion stuff, and it's away from that effusion. If it's a pleural effusion fluid, if there's like a lot of fluid pushing it out of the way. Breath sounds for consolidation would be bronchial, maybe some crackles, increased phrenitis for consolidation. Percussion's dull and the trachea stays midline. So remember, air is hyperresonant and you have decreased sounds. Fluid, fusion, consolidation, atelectasis would be dull. And then pressure pushes trachea away and volume pulls it toward you, pulls it toward the affected side. All right. That was 100 to 110. So like and subscribe if this was helpful. We'll see you guys in the next video. Hello, everybody. Welcome back. This is my original question 111. A 59-year-old man with a 10-year history of type 2 diabetes and hypertension presents with worsening fatigue, diffuse bone pain. He reports muscle cramps, pruritus on his lower legs. He's taken lisinopril and insulin, lab values, low calcium, high phosphate. H is elevated, creatinine is elevated, normal 25 hydroxyvitamin D, and low 125. What explains these symptoms? All right, so this is chronic kidney disease, secondary hyperparathyroidism. Basically, what you look out for in this one is hypocalcemia, hyperphosphatemia, because you can't get rid of it. Why? Because your kidneys aren't working, even though you have low calcium and phosphate. And what happens here is this is chronic kidney disease. So you have decreased GFR, and that causes your phosphate to be retained, which then leads to hypocalcemia. And that's where the PTH starts to rise. So it can help you with your hypocalcemia. So you get that chronic kidney disease, phosphate retention. The phosphate retention binds the serum calcium. And if you can't activate vitamin D, that makes this hypocalcemia problem even worse. So low calcium, high PTH, and low activated vitamin D. All right, there's the explanation. In metastatic bone lesions, you'd see hypercalcemia. In osteomalacia, you'd see a vitamin D deficiency. Hypo would have low. And primary has high calcium are also going to develop bone abnormalities over time. And that's because the kidneys stop doing their job. They stop converting vitamin D to its active form. And without the active form, the 125 form, you can't uptake a sufficient amount of that calcium. All right, now for this next question, I'd like for you to take a look at this drawing that I've done and tell me what is the condition associated with this drawing. Now, I know I'm not the best artist, but it's going to be associated with this question. A young boy, it could be anything, presents with progressive dyspnea and dry cough for the past 3 days. She underwent renal transplantation 8 weeks ago and has been on tacrolimus, mycophenolate, and prednisone. Temperature is at 101.8. Respiratory rate is at 28. And the chest exam shows bilateral crackles. Chest radiography shows diffuse interstitial infiltrates. Bronchoalveolar lavage reveals large mononuclear cells with basophilic nuclear inclusions. PCR detects DNA virus. Which immune cell dysfunction most likely contributed to this condition? All right, we know it's a DNA virus. And in fact, this is going to be a latent herpes virus. This is HV5, which is a correct answer. So CMV pneumonia is an opportunistic T-cell suppressed related infection after a transplant. So the CMV infected cells present viral antigens via the MHC1 complex. And those are recognized by the CD8 positive T cells, and that leads to the perforin, granzyme-mediated killing, the prevention of viral replication. And so you often see this with T cell suppression and post-transplant immunosuppressive therapy. In the histology, you see the ally inclusions. So yeah, CMV is T cell mediated. Eosinophils is against the helminths. Natural killer cells, CMV evades adaptive T cell immunity. All right, here are the associations. Transplants, CD4 below 50, graft versus host disease. It's a DNA virus. You suppress those CD8 positive T cells, and that can cause reactivation in the lungs, causing alveolar damage. Treatment is ganciclovir, valganciclovir. All right, next question. Look, that's you right there. A researcher is studying the binding properties of novel tetrameric protein to its signaling molecule. She constructs a graph of ligand concentration and notices the binding is sigmoidal. That means positive cooperativity among the binding sites. So the receptor ligand binding curve has a sigmoidal shape with a steep increase in the binding over the narrow range of the hormone concentrations. All right, so this is just a question about cooperativity. And this graph right here is going to be a cooperative graph, the sigmoidal shape, whereas this one is not the cooperative graph. Cooperative, sigmoidal. That's all we need to know. All right, for this next question, we have a 16-year-old boy, cystic fibrosis, comes to the clinic, has multiple pulmonary exacerbations in the past 6 months. FEV1 is 45% predicted, BMI 10th percentile. He skips nebulizer treatments because they take too long. He's alert and cooperative. What should be the initial response? It should be acknowledge the challenges of adhering to a time-consuming regimen. So your steps should always be you acknowledge, you validate, and then you problem solve later. So first you have to acknowledge, then later you solve this. Always acknowledge and try to understand what makes the adherence difficult. You have to acknowledge the frustration and explore the barriers. And then you use motivational interviewing, where you express empathy, you roll with the resistance, and you support self-efficacy. And you have to first empathize. You have to say, hey, I know it's hard to miss these insulin injections. First, you have to empathize, and then you have to validate. And then you can solve the problem. Explore those barriers. Acknowledge that it's challenging. For the next question, we have a 45-year-old Vietnamese woman, progressive nasal obstruction and intermittent epistaxis over the last 3 months. She's noticed a fullness of the left side of her neck. She's got a firm, non-tender mass in the left posterior cervical chain. Pharyngoscopy reveals a friable mass in the lateral wall of the nasopharynx. She's got Epstein's Barr. What is the most likely diagnosis? Nasopharyngeal carcinoma. It's just textbook right there. So nasopharyngeal carcinoma is a malignancy that arises from the epithelium of the nasopharynx. And that's because there's this fossa, there's the recess in the lateral nasopharyngeal wall. And this is really associated with EBV, especially if you see somebody from Southern Asia, Southeast Asia, and North Africa. And this presents with a non-squamous carcinoma, but there are also going to be some keratinizing subtypes as well. The thing to look out for is positive staining on Epstein's Barr virus, nuclear antigens. And so the symptoms are going to be nasal symptoms, right? Congestion, epistaxis, ear symptoms, the eustachian tube obstruction, conductive hearing loss, cranial nerve involvement as well. You can see, hoarseness, dysphagia. You're going to see some cranial nerve 9 and 10 action, cervical lymphadenopathy as well. And to treat this, we use radiation and chemotherapy. But this is linked, EBV is linked to nasopharyngeal carcinoma, especially in Asian populations. And this is present with epistaxis, nasal obstruction, and cervical node involvement. Now, let's talk about what this is not, because that's also equally important. This is not diffuse large B-cell lymphoma. While EBV can be associated with diffuse large cell, especially in immunocompromised patients, it is a lymphoid neoplasm, not an epithelial carcinoma. So this patient has a keratin-positive tumor, and that means it's epithelial origin, and so it's not going to be a lymphoma. And so it can't be diffuse large cell lymphoma. But you should be thinking of, large B-cell lymphoma in immunocompromised patients in lymphoid neoplasm, but not epithelial carcinoma. That's why it's not diffuse B-cell. Why is it not HPV, like oropharyngeal squamous cell carcinoma, HPV? Well, HPV is associated with oropharyngeal cancers. That's like the tonsils, the base of the tongue, and not the nasopharyngeal. And those tumors also are a little bit different. They stain P16 positive, not EBNA positive. And it's more common in like Western countries. Okay, so not it. Squamous cell carcinoma of the nasal vestibule, that's located in the external nares and unrelated to HPV. So basically, the high-yield recap for this is you got somebody from Southeast Asia with a nasal obstruction, hearing loss, and lymphadenopathy. Then it's going to be a nasopharyngeal carcinoma, likely Epstein's Barr virus. You're going to see keratin, and that shows you that it's an epithelial origin, and Epstein's Barr antigens like the EBNA positivity. That means you have Epstein's Barr virus involvement, and that makes nasopharyngeal carcinoma the best answer. So that is the recap on this question. All right. This question typically going to be an older patient. 61, former pianist, presents with a progressive stiffness and aching of her right thumb and wrist that began over the past 5 months. The pain is aggravated by playing and relieved by rest. That should make you already think of osteoarthritis. So piano, it could be tennis coaching. It could be a lot of things. Repetitive joint use. It's typically in elderly patients, maybe late 50s, early 60s. Osteoarthritis is the degenerative joint disease that's caused by mechanical wear and tear. You literally break down that articular cartilage, and that causes the formation of subchondral sclerosis, osteophytes, and joint space narrowing. So look out for that repetitive stress. Synovial findings are going to be non-inflammatory and also less than 2K white blood cell. Clear fluid, normal glucose, no crystals. So osteoarthritis is a mechanical joint disease, morning stiffness, less than 30 minutes, improves with use. Synovial fluid is non-inflammatory. So there's pseudogout, will be the deposition of calcium pyrophosphate dehydrate in the joint cartilage. That's pseudogout. And that would typically be with larger joints, like the knee, wrist, shoulder. And there you would have positively bifringent rhomboid-shaped crystals. If the answer were something like the deposition of calcium pyrophosphate. Positively bifringent rhomboid-shaped crystals. So that's pseudogout. Also, immune complex-mediated synovial inflammation is seen in rheumatoid arthritis and other autoimmune inflammatory arthritides. Rheumatoid arthritis is symmetrical and polyarticular. It also has morning stiffness and inflammatory synovial fluid. So you have a lot of white blood cells in the fluid. It's not going to be an acute bacterial infection in the joint space either. Here we have joint space narrowing. But if they were to say there's like some infection in the joint space, then that could be septic arthritis. And that has acute onset, severe pain, erythema, warmth, purulent synovial fluid. White blood cells are going to be galore, just like 50K of them, just all around. And if it said monosodium urate, then that's just gout. That'd be sudden painful swollen joint in the first MTP. So you'd have the needle-shaped negatively bifringent if it were gout. All right, so that's how to distinguish between all of these different conditions. Here you can read about them here. All right, next we have a 28-year-old man going to the clinic with 4 months of persistent diarrhea. The stool has blood in it, constant feeling of needing to defecate even after using the toilet. Colonoscopy shows mucosal inflammation from the rectum to the splenic flexure. Crypt abscesses and distortion. Which of the following complications is this patient most at risk for developing? The answer is colorectal carcinoma because this is ulcerative colitis. So the things to look out for are bloody diarrhea, tenesmus, which is the continual recurrent need to evacuate the bowels, left lower quadrant pain, erythema nodosum, and also with UC, you have the friable mucosa and continuous involvement starting at the rectum. And the biopsy shows crypt abscesses and mucosa, submucosa limited inflammation. So what happens here is it starts in the rectum and it extends proximally in a continuous fashion. And so inflammation is limited to the mucosa and the submucosa. It's not transmural. And the biopsy has crypt abscesses. There's not skip lesions or granulomas. So that's ulcerative colitis. Mucosal, submucosal, inflammation, continuous involvement, always rectal involvement. Every single time, gonna have rectal. That's why we wanted to mention the tenesmus in this question. Always rectal involvement, crypt abscesses, no granulomas. There's a risk of colorectal carcinoma, and it's associated with primary sclerosing cholangitis and Pianka. All right, now some other answer choices that they could have given you are like transmural inflammation with granuloma formation. That would be Crohn's disease, because Crohn's disease, it's a different beast, but there are a lot of similarities. Crohn's has skip lesions. There's also cobblestone mucosa, and it can affect any part of the GI tract, any part. This is also associated with fistula, strictures, and non-caseating granulomas. Now, they're also going to try to get you on diverticulitis, and that's common in elderly adults, and you would see left lower quadrant pain there. You would not have bloody diarrhea, and there's also not going to be diffuse mucosal inflammation on colonoscopy. And they could also try to get you on another question with C. diff. And that is typically after antibiotic use, you have watery diarrhea there. And endoscopy shows a yellow-white pseudomembrane that's not continuous mucosal ulceration. They could also try to ask about ischemia, acute mesenteric ischemia. Usually it'll be like an SMA occlusion, something like that. And that's associated with sudden onset severe pain, lactic acidosis, and also risk factors like atrial fibrillation. But this person just has ulcerative colitis, just a chronic disease causing bloody diarrhea and inflammation starting in the rectum. That's what you need to know about ulcerative colitis. The inflammation is limited to just the surface layers of the colon, and it spreads in a continuous path. Continuous. Unlike Crohn's disease, which just skips all around, and then it digs super deep into the bowel wall. All right, for the next question, we have a 46-year-old man. He's got bipolar disorder, treated with lithium. He's drinking tons of water. And what we know about lithium is that it actually impairs the ability of that collecting duct to reclaim the water because it stops that ADH. So what describes the tubular fluid tonicity relative to the plasma? Let's talk about the pathophysiology here. Lithium therapy for bipolar disorders disrupts the V2 channels. And so you get hypernatremia and increased serum osmolality. Why? Because that water leaves. The water is gone. It can't be reuptaken by those V2 channels anymore. So the lithium inhibits the V2 receptor signaling. The collecting duct fails to absorb the water. And now the urine is just full of water. So the medullary gradient gets washed out. And so then you just lose the ability to concentrate at all. And hypernatremia, polydipsia, polyuria, you have no improvement even after you give them desmopressin. Now, we have to know what's happening in the proximal convoluted tubule, and that's the segment that reabsorbs 65% of the filtered sodium and water. That happens isotonically. Because both solutes and the water are reabsorbed proportionally, the tubular fluid osmolality remains isotonic. And that's always true. It's true in every condition, even nephrogenic diabetes insipidus. And the DCT, the distal convoluted tubule, is impermeable to water, but it actively reabsorbs sodium. And so the tubular fluid becomes dilute or hypotonic as the solutes are removed. But in normal and DI patients, the segment will be lowering the tubular osmolality. So you'll see hypotonicity there. And the medullary collecting duct is at the end. And in healthy patients, that's the site of the ADH action. And that's where water is reabsorbed through the aquaporins. But in nephrogenic DI, aquaporin insertion will fail because of that lithium that interferes with the V2 receptor-mediated CAMP signaling. And so no water is absorbed. And so it's going to be dilute and hypotonic even in the medulla where the interstitial osmolality is high. So even though you have high plasma osmolality, the urine is dilute because of the collecting ducts. And desmopressin fails to concentrate it. Whereas it would really help if this were just central DI. So without that CAMP, aquaporins can't work. Proximal tubule is going to be normal, but the collecting duct is hypotonic because these guys are watertight. And then you can't absorb it at the end, so it's also hypotonic as well. All right, there are the kidneys. All right, here's the next question. We have a 43-year-old man admitted with a high-grade fever, altered mental status, and painful swollen right thigh. Had minor surgery, 104, super high fever, knee with palpable crepitus. He is obtunded, withdrawals from painful stimuli. Here are the labs. What describes the mechanism? All right, so for this question, we have to know what's happening, and this is toxic shock syndrome. How do we know? We got a fever, hypotension, multiple organ dysfunction, so renal and hepatic, and there's diffuse erythematous rash after a nasal surgery, and that's a known risk factor for toxic shock. And that's because of the nasal packing that's colonized by Staphylococcus aureus. So toxic shock is caused by Staphylococcus aureus via the TSST1 pathway or Streptococcus pyogenes through exotoxin A or C. And they both share the same mechanism for toxic shock. And the mechanism is you have that toxic shock syndrome toxin, TSST1, that binds non-specifically to the T receptors and the MHC class II molecules on the antigen-presenting cells. It bypasses the normal antigen specificity and it activates 20% of the T cells at once. And so that's a huge, as you can imagine, cytokine release. And so now you're just swarmed in IL-2, IFN gamma from T cells, IL-1, TNF alpha from macrophages, and that leads to a cytokine storm. So you have shock, organ failure, and rash. So that's our answer is C. Trap answers, caspase, cleavage to apoptosis. Definitely not toxic shock. That's like a viral bacterial manipulation. Inactivation of VF2, that's diphtheria and Pseudomonas. Lecithin hydrolysis is Clostridium perfringens alpha toxin. Serum protease disrupting the junctions is exfoliative toxin of Staph aureus and scalded skin syndrome. That is exfoliative toxin in Staph aureus and scalded skin syndrome. So yep, it's the bacteria that makes your immune system go into overdrive. All right, for the next question, we got a little baby, 4-day-old infant, presents with vomiting, lethargy, poor feeding. Examination reveals signs of dehydration and ambiguous genitalia. Sodium is 122, potassium 6.5. So that's a low sodium, high potassium. Glucose of 48. Oh, genetically female. So this is congenital adrenal hyperplasia. And they give us the 17 is markedly elevated as well. And that's diagnostic for it. 11 beta hydroxylase. That'd be hypertension due to excess 11-deoxycorticosterone. But this patient is hypotensive. And so that can't be the answer. So it's going to be 21 hydroxylase deficiency causing that elevated 17. Aromatase, that's involved in the maternal virilization during pregnancy, does not cause salt wasting at all. 17 alpha hydroxylase, that would cause hypertension and sexual infantilism. And this guy right here is super rare, probably won't see it on test day. But the takeaway for this question is that 21 hydroxylase is required to make cortisol and aldosterone. And so deficiency leads to lower cortisol, lower aldosterone, and increased androgens. So you get the virilization in the XX infants. And 21 hydroxylase deficiency is the most common cause of congenital adrenal hyperplasia, and it affects newborns with ambiguous genitalia, salt wasting crisis, so hypernatremia, hypercalcemia, and dehydration, and also elevated 17-hydroxyprogesterone. You give them glucocorticoids and mineral corticoid replacement. All right, in this question, we have a 10-year-old boy brought to the pediatric clinic for evaluation of skin nodules and fatigue on exertion. His father died at 36 from myocardial infarction. Fundoscopic exam shows gray-white deposits near the corneal margins. Lab shows total cholesterol 620, LDL 540. All right, so what's happening here? You could see these firm yellow nodules, these tendon xanthomas. He might also have some corneal problems, some corneal arcus, and elevated LDL cholesterol. These are hallmarks of familial hypercholesteremia. And this is due to a defective or absent LDL receptor-mediated endocytosis. So you have high LDL, right? Like, look at that. That's extremely high. Tendon xanthomas, so like the Achilles and extensor tendons, and lipid deposition as well can occur in the cornea, and premature cardiovascular symptoms, so like chest pain, dyspnea, things like that. And so the answer is going to be the impaired clathrin-dependent LDL receptor endocytosis. And so the pathophysiology of familial hypercholesterolemia is a mutation of the LDL receptor or on the ApoB100 or the PCK9, those proteins. And the LDL receptors on the hepatocytes bind the LDL to internalize it through the receptor-mediated endocytosis, and that relies on the clathrin-coated pits. So yeah, if you see somebody who has like a heart attack before they have their driver's license, then they probably have FH. Look for tendons and corneal arcus and LDL levels above 500, just a dead giveaway. And then you have to know the mechanism. Cabulin deficiency, non-clathrin endocytosis, not LDL. So that's why A is wrong. These other mutations, they're different diseases. ApoC2 would raise triglycerides because you can't clear the chylomicrons. And snare defect affects the vesicle fusion. All right. Hopefully you guys found this helpful. If you did, please consider liking and subscribing. And we'll see you guys in the next video. Hello, everybody. Welcome back. I feel like I just figured out how to use this microphone. This is NBME 29. I've created original questions that cover topics that I believe are important for you to have mastered by the time you finish this exam. So here we go. Our first question involves a 66-year-old man. It could also be a female, hence our demographic photo here. With chronic kidney disease and hypertension, presents with sudden onset left ankle pain and swelling. He has difficulty bearing weight and reports chills and fatigue. Temperature is 101.8. On examination, left ankle is warm, erythematous and tender. Novial fluid, white blood cell count of 78K, 94% neutrophils, gram shows abundant neutrophils but no bacteria. Which of the following is most likely the cause of the patient's symptoms? Okay, so in this type of patient, you're going to see typically it's some sort of like a sudden fever. They might have like a very painful knee, and then maybe also diabetes, something like that. All these things are pointing to infection risk. And then you look at the joint fluid, and what do we see? White blood cell count that's pretty high in neutrophils, septic arthritis. And also they could tell you that, hey, there are no crystals, then it's not gout or pseudogout. And also they'll mention that it's cloudy. They'll give you some detractor answers. For instance, they'll say, oh, is it gout? Well, no, that has uric acid crystals and fewer white blood cells. Is it pseudogout? No, pseudogout would have calcium crystals, and there's none of that. What about DVT? Well, that would cause a leg swelling, not that hot red joint. Okay, so that's the way to think about this question. The cause is septic arthritis. That's the cause. Calcium pyrophosphate is pseudogout rhomboid crystals. Erythema nodosum would have the nodules in the shins. Skin manifestation. Reactive arthritis is post-infectious, and it'd be asymmetric oligoarthritis after some sort of an infection. Not going to be as acute. Arthrosis, bloody aspirate. So yeah, septic arthritis can actually just destroy a joint in like 48 hours. They'll present with acute, red, hot joint pain, and also some systemic signs like fever. In our next question, we have a 9-month-old boy from Middle Eastern descent brought to the clinic for pallor, poor feeding, hepatosplenomegaly. Lab testing reveals a hemoglobin level of 5.8. Now, this could be a male, could be a female. Peripheral smear shows microcytic hypochromic RBCs with numerous nucleated red cells. Genetic testing confirms a mutation affecting intron-exon splicing of both beta-globin alleles. What explains the anemia? It's the accumulation of unpaired alpha globin chains. So normal adult hemoglobin, so HbA has 2 alpha and also 2 beta chains. And in thalassemia major, mutations like splice site defects will greatly reduce the beta globin production. And so alpha globin is still going to be made normally, and so there's an imbalance. There are too many alpha chains and not enough beta chains. And so extra alpha chains will clump together. You'll get these alpha 4 tetramers, which are insoluble, and they damage the red blood cells and they cause severe anemia. So those would be increased. Beta tetramers would be a feature of alpha thalassemia, which makes sense because 2 alphas, 2 betas is what's needed for adult hemoglobin. And so the answer is the accumulation of the unpaired alpha chains. That's what's happening here. So yep, it's beta thalassemia major. Gamma globin tetramers would be Bart's, seen in alpha thalassemia. Low EPO would be anemia of chronic disease. Delta globin. Here we should definitely just be thinking of like alpha, beta for your thalassemias. Beta thalassemia would have decreased beta chains, and so you have excess alpha chains. Alpha thalassemia has decreased alpha chains, so you have excess beta chains, or, your gamma tetramers. The thalassemia essentially denotes the deficiency, is the way to think about that. Okay, next we have a 27-year-old woman with a history of schizoaffective disorder brought to the emergency department due to confusion and muscle stiffness. This could also be, a man, elderly woman, whatever. She recently started on risperidone 4 days ago, following an acute psychotic episode. After arrival, her temperature is 40 degrees Celsius, so 105 holy Toledo muffins. That's high. Heart rate 130. Physical exam reveals generalized muscle rigidity. Okay, so already I know that this is neuroleptic malignant syndrome because look at that fever. Oh my goodness. They took a dopamine blocking antipsychotic and now their fever is through the roof. Definitely neuroleptic malignant syndrome. So they probably started risperidone, could be haloperidol, like a high potency antipsychotic. And now they have a super high fever, muscle rigidity, that lead pipe rigidity is how it's commonly known. So the answer is indeed C, neuroleptic malignant syndrome, after you have a dopamine blocking antipsychotic. You get that muscle rigidity, altered mental status, they'll be disoriented, they might be agitated, they have autonomic instabilities of tachycardia, labile, BP, increased CK, the muscle breakdown from the rigidity will also take place. The mechanism of action is important. The cause here is you have that antagonism of your D2 receptors, your nigrostriatal, and your pathways are going to be blocked from antipsychotics like haloperidol, risperidone. Nigrostriatal blockade causes severe muscle rigidity, that lead pipe rigidity. And the hypothalamic blockade causes the loss of the dopamine regulation and autonomic instability and hyperthermia. So you have sustained rigidity, muscle breakdown, and that increases your CK and rhabdomyolysis. So first of all, how do we treat this? We have to stop the antipsychotic. You have to give supportive care, right? Hydration, cooling. Dantrolene is going to inhibit the ryanodine receptors in the skeletal muscle, right? You got to inhibit those with dantrolene. And that would cause less calcium release and so less rigidity, less heat. Bromocriptine, mantidine, these are dopamine agonists and they restore the dopamine signaling. Neuroleptic malignant syndrome is too much dopamine blockade, decreased dopamine activity, cause rigidity, fever, and autonomic dysfunction. That's what's going on. Serotonin syndrome, hyperreflexia clonus, malignant hyperthermia, exposure to anesthetics, no surgical anesthesia history there, so it's not going to be malignant hyperthermia. Tardive dyskinesia would be lip smacking, chorea, that stuff. And this is super important because it has a mortality rate of like 20% if it's untreated. Next, we have a 2-year-old girl with adenosine deaminase deficiency undergoing experimental gene therapy with an integrating retroviral vector. After initial improvement in immune function, she returns with persistent fevers, fatigue, cervical lymphadenopathy, peripheral blood smear reveals lymphoblasts, flow cytometry reveals T-cell markers, karyotyping is normal, but molecular analysis reveals vector insertion upstream of the TAL1 gene. What explains the mechanism of her condition? Adenosine deaminase deficiency. All right, so this is probably going to be a young kiddo, boy, girl. We got some T-cell markers and vector insertion upstream of the gene. All right, so what's happened here? This is T-cell leukemia after gene therapy. And this is a risk when retroviral vectors integrate near the oncogenes like TAL1 gene. So this is a mechanism called insertional mutagenesis. You activate the oncogenes and it leads to clonal malignant transformation. And there are some things to watch out for questions like this. What comes to mind should be, you should be on your radar, you should be thinking about like P53, because the P53 deactivation, that's common in tons of cancers, but retroviral gene is going to be different. You could be thinking about PRB, phosphorylation, that's downstream cell cycle control. It's not caused by retroviral insertion. You should be thinking of other cancer associations, maybe that 922 Philadelphia chromosome for BCR-ABL, the Philadelphia chromosome for CML, other reverse transcription like, P10 is a tumor suppressor. But we're looking for what causes our leukemia. Here it's going to be the integration of a transgene near a proto-oncogene. And it's important if you have a adenosine deaminase deficiency, then you've got SCID, right? The boy in the bubble disease. It's an X-linked severe combined immunodeficiency disorder. And so you're going to use retroviral gene therapy. So a virus carries a normal copy of the missing gene and it integrates into the child's bone marrow and the stem cells. Those are the cells that make the normal immune cells. And at first it's working, but then years later, the child gets like T-cell leukemia. So the question that they're really asking is like, okay, how did this happen with this kid who had SCID? They're asking what went wrong. Well, retroviruses don't choose where they insert the DNA. They just kind of integrate randomly into the host genomes. And so some unlucky ones, the virus inserts the DNA right next to an oncogene. And that causes the oncogene to be turned on too strongly. And then you get cell growth, which is cancer. So this is insertional mutagenesis. Now, what you should know about P53, PRB, and also P10 is that these guys are tumor suppressor genes. So the mutations there would cause cancer, not from retroviral insertion. So the Philadelphia chromosome, the BCR-ABL, CML, that's not related to gene therapy at all. But the big takeaway for this question is that retroviral gene therapies have risks. They can cause random integration and activation of oncogenes. And if you activate your oncogenes, then boom, you got leukemia. So that's what they're testing you on. All right, question 125, 65-year-old woman, history of type 2 diabetes and hypertension, presents with confusion, progressive fatigue over the last 3 days. Could be an elderly man as well. She missed her dialysis session early that week. Vitals show heart rate of 98, T of 36 degrees Celsius. She has periorbital and pedal edema. Neurological exam shows us asterisks. What's the cause of her disturbance here? And they give us a ton of labs. All right, so what's going on in these labs? Do they give us a pH? Oh yeah, there it is. Okay, I was like, wow, where's the pH? 7.3. Okay, so that's low. So we're dealing with acidemia. HCO3 at 12. Okay, well that's low. So that's metabolic acidosis. PCO2 is at 25. That's also low. So that means the lungs are compensating with some hyperventilation. And now let's calculate that anion gap. And anytime you do the anion gap, it is the sodium minus all the negative stuff. So like chloride, bicarbonate. And we're going to get a pretty high anion gap when we do that. Normally it's like less than 12. This is going to be pretty high. And so the causes of the anion gap, elevated anion gap metabolic acidosis are mud piles. So that would be methanol, uremia, which is to say renal failure. D stands for DKA. P is propylene glycol. You're gonna glycol. Ghostbusters. I is INH, or iron. L is lactic acidosis. E is ethylene glycol. It's mud piles. So it's salicylates. So here we have severe congestive heart failure. So very high creatinine, 8.4, also high BUN. There's no ketones in the urine, no glucose in the urine, no drinking alcohol. So it's not ketoacidosis. And so it's going to be uremia from acute kidney injury due to congestive heart failure. Why? Because the kidneys are not being perfused. So we got some uremia going on here. That edema, uremia. The sick kidneys cannot excrete the acid, so you get uremia, high anion gap metabolic acidosis. That's what's going on in this question. Okay, here we got a 31-year-old woman presented with 9-month history of progressive vision difficulties. Notice some spontaneous nipple discharge. Pretty easy question. This is going to be probably that a nipple discharge is probably going to be prolactinoma that inhibits the gonadotropin releasing hormone. So that's our answer. Maybe a way that we could make this question a little harder is we can look at a kind of diagram like this. And here we have to know that this right here is pointing to the hypothalamus. This right here is the thalamus. That's going to be like the midbrain. And here's where you'd have like a pituitary problem, pituitary adenoma. And that could be like some optic chiasm compression of the pituitary adenoma. But here she's got visual testing, unable to see objects. And in this case, we have hyperprolactinemia suppressing the GnRH, manifesting amenorrhea and low LH and FSH. The pituitary mass is pressing against the optic chiasm, explaining her bitemporal hemianopia, which looks like that. It's the loss of the vision on the outer half. Okay, in our next question, we could have a 29-year-old pesticide factory worker. Maybe it's male, maybe it's a female. Brought emergency department, complains of blurry vision, excessive sweating, and abdominal cramping, diaphoretic bradycardia, and wheezing with pinpoint pupils, parasympathetic activation. Colleague mentioned he was exposed to some barrel of organic phosphate. The toxin most likely forms a covalent bond with which amino acid residue? You just have to memorize this one. It's serine. This is DFP, disopropyl fluorophosphate. It's an organophosphate that irreversibly inhibits acetylcholinesterase by binding to the serine residue at its active site. So acetylcholinesterase is the enzyme that normally breaks down acetylcholine. And at its active site, there's a serine amino acid that does the actual chemical cutting. So you get an organophosphate that would stick to the serine and it'll block it forever. So acetylcholinesterases can't work. So acetylcholine builds up and you get an overstimulation of the nerves and you get a cholinergic crisis. So to answer this one correctly, we have to know the mechanism of organophosphate poisoning, especially at the molecular level. Organophosphates, maybe a child has this as a pesticide. It's a chemical like disopropyl fluorophosphate is a potent irreversible inhibitor of acetylcholinesterase. And so it binds to the serine residue at the active site of acetylcholinesterase enzymes. You might think it's histidine, and that is part of the catalytic triad, but organophosphates do not bind to histidine. It participates in proton transfer during the catalysis, but it is not the nucleophile itself. So a pesticide-like chemical is poisoning a kiddo or poisoning somebody, and it irreversibly inhibits acetylcholinesterase, and that an enzyme, you have to know, uses the serine residue to break down acetylcholine. The toxin covalently binds to the serine, and it stops the enzyme, and it causes too much acetylcholine, which leads to sweating, the twitching, and the weakness, and so serine is going to be the target there. Next, we have a 61-year-old woman. It could also be a man, so I've drawn a man there. Brought to the emergency department by her daughter, who says the patient began speaking nonsense. Okay? So this is probably going to be Wernicke's aphasia, nonsense. They could also say, all right, we got like an old woman or a man brought to the emergency room by her daughter. And basically what they're trying to get you to understand is the language processing region of the brain, like Wernicke's area, and the way that Wernicke's area and Wernicke's aphasia looks. And it's the left posterior superior temporal gyrus. That's Wernicke's area. All right, it lies in the dominant hemisphere, usually the left, and it corresponds to the Brodmann's area 22. But there, if you have like an MCA, like a middle cerebral artery stroke, then you can have fluent aphasia, where the speech is fluent and has normal grammar, but the rate is nonsensical. Or paraphasia, word substitutions, neologisms, made up and invented words, impaired repetition, or a lack of insight. So Wernicke is just word salad, right? MCA stroke, posterior superior temporal gyrus. So the answer is the inability to repeat simple phrases here. Where you have, that's also involved, Wernicke's aphasia, so the Wernicke's area is also involved in repetition. So repetition would definitely be impaired there. Slow effortful would be Broca's, hemiparesis of the right arm, Broca's aphasia with frontal lobe involvement. Right-sided sensory neglect, parietal lesion, inability to recall 3 objects would be short-term memory problems. This is Wernicke's aphasia. All right, here we have a 3-year-old male infant born 36-week gestation, develops irritability, poor feeding, intermittent tonic-clonic movements. Temperature 96.6. Examination shows tense, bulging anterior frontanelle. His mother did not receive prenatal care, and her membranes ruptured 32 hours prior to delivery. Lab studies show leukocytosis and blood cultures pending, which of the following organism is most likely responsible. So you might see some elevated protein in the labs. Maybe the glucose would be low. White blood cells are going to be like elevated. There's a neutrophil predominance. Basically, we have to understand neonatal bacterial meningitis and the pathogen based on the clinical signs and lab findings, all that stuff. Now, E. coli is the most common cause of early onset neonatal meningitis, especially in the first 72 hours of life. So some risk factors they might usually say is the lack of prenatal care, premature rupture of the membranes, prematurity, And this is a gram-negative lactose fermenting rod. And so you can easily identify this on McConkey agar. It causes fulminant presentation, so poor feeding, temperature instability, bulging fronts, and seizures and coma. CSF findings and bacterial meningitis are going to include high white blood cell count with neutrophil predominance, low glucose, and elevated protein. The elevated protein is due to the increased permeability and the inflammation. Low glucose is because the bacteria are just going to be chomping away. They're going to be eating that glucose. High white blood cell with neutrophil predominance makes some sense too. Basically, this E. coli is just causing the sepsis, causing meningitis in this kiddo, and it's just hours or days after the birth, which kind of gives it away. You give them ampicillin and gentamicin as well for empiric first-line treatment. Now, the question is, how do we distinguish this from other diseases? Well, hypothermia, seizure, bulging frontanelle means we got a CNS infection, and E. coli crossed the blood-brain barrier. Listeria is much less common, especially in the absence of maternal food exposure. Strep pneumonia, be rust-colored, otitis media. Staph epidermitis has shunt-associated infections, more like with a catheter. Neisseria, meningitis, you'd see that in college dorm rooms. Early onset neonatal meningitis is probably going to be E. coli, just because usually they'll give you some sort of a CSF culture that'll make it really clear. They might even tell you it's a gram-negative rod if they're being easy. Lactose fermenter that's unique to E. coli. Neisseria meningitis, that affects older infants, children, and adolescents, not neonates. Streptococcus pneumonia is more common in toddlers and older children. So this is really just a timeline thing. Listeria could be a early neonatal meningitis, but it's a gram-positive rod, not a gram-negative rod. And it's usually with some contaminated food or transplacental transmission, something like that for listeria. So the big kind of takeaway here is that we have a newborn with seizures and a bulging frontanelle, which is neonatal meningitis. CSF has a bacterial infection, and usually the culture will show lactose fermenting stuff, and that will point it to E. coli. But yep, crosses the blood-brain barrier, E. coli. Let's do one more question here. All right, here we have a 30-year-old woman, fatigue, dark urine, diffuse itching for the past 10 days, returned from a trip abroad. She was prescribed azithromycin doxycycline for presumed respiratory infection. Began taking a new contraceptive pill 6 weeks ago. On examination, she has mild scleral icterus and excoriations on the forearm. Lab studies reveal, high bilirubin. Which of the following is most likely in this patient? Wow, look at that GGT. Normal is 0 to 30. That's 280. So this is going to be some sort of a drug-induced liver injury. The total bilirubin should be way lower than that. Usually 0.1 to 1.2. Direct, that's also super crazy high. Should be nothing to 0.0, to 0.3. Alkaline phosphatase, it's also super high. Should be 40 to 120. AST about 80 to 40, that's super high. ALT about 7 to 50 something, 56. That's a little bit high. The GGT is off the charts, my guy. All right, so we have some form of drug-induced liver injury. The answer is dilated bile caniculi containing bile plugs. So they have cholestatic symptoms, right? Pruritus, scleral icterus, dark urine. Started taking a new pill, that helps to understand it's the medication causing this. But the lab values really just give this away. We have disproportionate, super elevated alkaline phosphatase and GGT relative to the AST and the ALT. And that's going to be suggestive of cholestasis. That's the slowing or the blockage of the bile flow from the liver to the small intestine. There's also direct hyperbilirubinemia that supports the impaired flow of the bile. And so the reason why it's these bile plugs is because we know it's cholestasis. Here's another way of saying drug-induced cholestasis is marked by canalicular dilation of the bile plugs, elevated ALP, GGT, and mild ALT, AST elevation as well. And it's associated with oral contraceptive and antibiotics like amoxicillin, clavulanate, and also herbal toxins. Now, it's not going to be some form of necrosis that would show super high ALT and AST, in the thousands here, but there's no evidence of that. We're not seeing any signs of chronic liver disease like hypoalbuminemia and prolonged PT. Hepatocellular ballooning and degeneration would be steatohepatitis from alcoholic or also non-alcoholic fatty liver diseases would be hepatocellular ballooning. And that's associated with macrovascular steatosis. That's over time, not acute. Iron deposition in hepatocytes and the Kupffer cells. That would be hereditary hemochromatosis, would be Kupffer cells. Iron deposition for sure. And so there you'd have elevated ferritin, transferrin, saturation. So basically we have a woman who's developed some drug-induced cholestasis after starting herbal supplements. Her labs show high bilirubin, high LP, GGT, classic for cholestatic drug-induced liver injury. So it shuts down the bile transport system. Oral contraceptives can do that especially when they combine with antibiotics. So cholestatic drug-induced liver injury is what's going on with this patient right here. All right, if you found this helpful, then like and subscribe. We'll see you guys in the next one.